Hey everybody, it is that time for the Thursday Thrive video. And this week we have been talking all about transfusion stuff like red blood cells, platelets, cryo, and throw that on Instagram. And then I gave you some tactics on Facebook on how to kind of prevent like transfusion. So I really just briefly wanted to go through a case scenario today. Hey, be quiet. And what it looks like to kind of transfuse intra-op when things kind of, when your patient starts bleeding and how you kind of walk through that and what you kind of think about. So that's what I wanted to talk about today. So let's dive on in. So let's say that you have a 62-year-old female coming to you very cachectic. She just got newly diagnosed with colon cancer, like fairly advanced, and she is undergoing a bowel resection. Other than that, no real like history or anything like that. Fairly healthy besides this cancer. Her starting H&H is 10 and 33, not bad. Other labs are all fine. Blood pressure 107/68, heart rate nice and normal. You put her to sleep with no problems. You get the tube in, you paralyze her, you get all your your OG, your NG in, all that good stuff, and you are cruising along, right? So then the blood pressure starts to drop a little bit. Okay, that's fine. She's probably a little dry. Start giving her some fluids. You probably got some LR up. Um, uh, you're kind of maybe thinking about like maybe some neo and ephedrine, like besides the fact that she's got cancer, she is dry, she's cachectic, you've got the anesthesia on board, so you can also kind of drop off your gases a little bit to help with that. You give her some neo, give her, that's kind of helping, not really, give her ephedrine, it's kind of helping. And then you're still cruising along and you're like, okay, why is my blood pressure like still bad, right? So then you kind of go through the whole thing like, all right, let me like double check the cuff, like check, look at the patient, obviously. Is the cuff okay? Is my IV okay? Like, is it actually really working? Are the drugs going in? And then, you look over the drape and you kind of like peek over and you're like, so what's going on, guys? And they're like, well, I think we might have come into some bleeding. So now you're like, okay. So you kind of take an inventory around. You're like, all right, well, my pressure is like really low. It's not, it's not really going up. So at this point, I would actually call for probably another pair of hands. Heart rate starting to creep up to try to compensate for the low blood pressure. At this point, you have like neo like flying in and you're like, okay, this is not working. So what do we do? So obviously we're probably looking at some type of hemorrhage, hypovolemic, also vasodilatory. So what I would start doing is anytime it gets hypotension and stuff gets really bad, I get that gas usually off. I usually get the gas really low or off, start flying in fluids. Do we have a type and cross? You can also give a little bit of Versed as well to kind of help, because if you're losing your gases, you might want to be thinking about, I don't want, this patient to remember anything. So might give some Versed. Get the type and cross in. What do you have for lines? Do you have 2 large bore lines that you can infuse fluids and blood through? Then I would start getting an A line as well to get some really accurate pressure readings, which might be difficult considering your pressures in the toilet. But these are all of kind of the things you're thinking about. And then you might even need to start like other pressors, right? Like you might need to start maybe some Levofed. If you're not getting any results with your neoephedrine, you got her on a drip, you've got the gases off, they're trying to combat the bleeding. I mean, obviously we need to get some RBCs on board. Oh, let me go back up here. So you finally get the packed cells, you start administering that. Blood pressure, kind of helps, gets better a little bit. You pull off an ABG, and what are you probably expecting to see? Probably metabolic acidosis, right? She's probably being acidic because of the loss of volume. And plus, with her cancer diagnosis and whatever else is going on. So at that point, you're going to want to help out the acidosis. You would change your vent settings. I would increase her tidal volume. I'd increase her rate to start getting that some CO2 blown off to see if you can help compensate a little bit. I would potentially think about giving some bicarb at this point as well to help out. And then obviously I would give probably 1 to 2 units of blood. She should respond to that. I would get another ABG after that. Hopefully you've went up 1 to 2 points on your hemoglobin. And you also want to watch that calcium, right? Because the citrate in the blood binds up the calcium, and they usually are hypocalcemic. And then calcium is also going to give you some squeeze of your cardiac output to help the heart out a little bit. So I would actually definitely probably give some calcium in this situation to help with the, contractility, help with your blood pressure, all that good stuff. Maybe think about getting some platelets on board, or some FFP as well to get some clotting factors going, depending on, your blood loss. So all these things are going on, you're managing all the things, you're talking to your surgical team, and these are some of the things that you really need to start thinking about. So number one, is it safe for surgery to continue? You got to look at where, they're at. You got to talk with the surgeons and be like, guys, I'm really struggling here. If you can get them stabilized and you think that, okay, we can probably still continue, go for it. But that's one of the thoughts you need to have with your surgical team, have with your preceptors, have with, your other CRNA, anesthesiologist, whoever it may be. But can we safely continue surgery? Is it worth it? Does the patient need to finish having the surgery at this time, right? So that's a question you got to think about. And then I talked about here, managing the ABG, managing all the things, managing your pH, working on ventilation strategies, maybe getting some bicarb going, looking at your base deficit, all the things. So that's all, what you're constantly going to be doing. I'd recommend after getting 1 to 2 units in, grabbing another blood gas, and then, maybe in a half hour after that, grabbing another one, and really see, are we trending in the right direction? That can also help kind of verify, can surgery continue? Are we correcting this, imbalance here, or other bad things happen that we need to fix? And then do you keep this patient intubated? Obviously, when you do any type of mass transfusion, you're always worried about, fluid overload status, pulmonary edema. Sometimes you want to give Lasix depending on how much you give somebody with blood products and stuff like that. That's another thing. Do we call the ICU and try to work on getting them bed to keep them intubated? So these are all the things you're going to be thinking about, all the things you're going to be managing. And this is why it is so important for you guys to have, your solid ICU experience, right? To understand how all the pressors work and all the dosages and all the pharmacology of it and all the physiology behind, the patient's conditions plus the surgical conditions. So you need that solid base as an ICU nurse to really excel and to really be awesome and to manage these situations in the operating room. Okay. All right, guys. I hope that was helpful. I hope you guys have an awesome weekend. I am cheering you all on. Apparently he is too. And have a great weekend. I will see you guys next week. Okay. All right. Bye.